my name is Princess and today we're gonna do a newborn assessment. So first things first, of course, we have to make sure that we check the doctor's order before we do it. And after checking doctor's order, we're going to gather our equipment that we will be needing. So for newborn assessment, we'll be needing a tape, oxygen saturation monitor, the bolimeter, bulb syringe, stethoscope, thermometer. Those are the things that we will be needing. After gathering the materials, we're going to the patient's room. We're gonna do our proper hand hygiene. It is super important that we do our hand hygiene because we are touching the baby and we don't want to give the baby infectious diseases just because we didn't wash our hands. So wash our hands. Number one rule, wash the hands, okay? So after that, we're going to the room. We're gonna introduce ourselves to the mother, to the patient, and explain that we are just going to do a newborn assessment. After that, we're going to put the baby here. So baby is all ready for us here. First things first is we're gonna do the respiration of the baby, and the normal respiration rate range into 30 to 60 breaths per minute. Okay, so when we're doing this, we're gonna put our hands at the abdomen of the baby, and then we're gonna count as the abdomen, like do the inward and upward motion, because the baby are often called as abdominal breather because we can see they have irregular breathing pattern. So that's how we count the breathing of the baby. So we're gonna do it for 1 full minute, okay? So after doing the respiration, we are going to auscultate the apical pulse of the baby. So we are going to use the bell of our stethoscope, and then we're gonna put it at the fourth intercostal space of the baby. And then we're going to do it for 1 full minute. You might ask, why fourth intercostal space? Why not fifth? That is because we know that babies are tiny, and then usually we have a tiny stethoscope too. So we just put it at the fourth intercostal space, and then we can hear the apical pulse of the baby. So do it for 1 full minute, and then we're all good. Normal rate for apical pulse of the baby is around 110 to 160 beats per minute. So after auscultating the chest, since we're here, we're gonna auscultate the chest. So for doing the chest auscultation, we're gonna do it side to side. I recommend you to do it this way because if we're gonna auscultate the chest of the baby, what we're gonna hear is their heartbeat. So if we want a clearer hearing of the chest, we're gonna do it at the base of their lungs. And then we're gonna do it for a full minute as well. What we're looking here for is if the patient have any murmur or any adventitious sound. So after doing the auscultation of the chest, we're gonna do the abdomen. So for the first 30 minutes of life of the baby, it is normal if they don't have bowel sound, but after that, it must be present, okay? If not, then we have to notify the doctor for that. So we're going to auscultate it. So from the right lower quadrant to the right upper, of course, we have to make sure that we're auscultating it not over the clothes, okay? So right lower to right upper, and then left upper to left lower quadrant. And we're gonna document the findings, like if the patient is hypo or hyperactive, normal pitch sound, things like that. So after auscultating the chest, what we're gonna do is the temperature of the baby. So when we are doing the temperature of the baby, so axilla is the most common that we use, but for the rectal, we don't use it. We don't recommend it because of the risk of injuries of the baby. So the right way that we do it is that we're gonna get our thermometer here, put it at the center of the axilla, and then hold it until it beeps. And then after it beeps, it means that it's done. So make sure that it's not like this, like it's over like that. It means that it's not getting the right temperature of the baby. It's getting the blanket temperature of the baby. So we want it not like that, but like this. It's supposed to be at the center of the axilla of the baby, okay? So after getting the temperature, the normal temperature is at 36.5 to 37 degrees Celsius. So after that, we're done with the temperature. Now we're gonna do the blood pressure of the baby. So when we're doing the blood pressure of the baby, we're going to choose a side, left or right side. After choosing a side, we are going to do it on the upper extremities and into the lower extremities, like at their foot, one at their hand and one at their foot. Why are we doing this? Because we are looking for the differences of the result of the blood pressure, because then we might see if there is the presence of coarctation of aorta. What is coarctation of aorta? So think of it this way. Think of the aorta as the highway, the main highway that gives oxygen-rich blood into the whole body of the baby. Now, if there is a presence of coarctation of aorta, it means that there is like a narrowing into that highway, into that aorta, and it gives a hard time for the blood to give the blood all over to the body. It means that like the oxygen-rich blood, is not going into the lower extremities. So we have to document those findings and we have to notify our doctor for that, okay? So after that, after doing that, we're gonna do the oxygen saturation of the baby. So oxygen saturation of the baby, normal is at 92% and above. That's the normal range, and we are supposed to have like a like this thingy. So this is a blood pressure cuff, but our oxygen saturation is same thing like this. So this goes at the foot of the baby here, and then there is supposed to be this circle here is supposed to light up, and it means that it's working, and we're just going to connect it into the monitor, the SaO2 monitor, and that's how we get the oxygen saturation of the baby. So while we are doing this assessment, we are looking at the respiratory distress of the baby. So what are the signs and symptoms of respiratory distress of the baby? So we have nasal flaring, grunting, and we have the retraction. So when we say grunting, that is when the noise that we heard at the expiration of the baby, when the baby exhales. Even without stethoscope, we can hear it. So that's grunting. And when we said retraction, that is when it's an inward movement of the chest when they are breathing. So those things, if we see that the patient is in respiratory distress, we have to stop the assessment immediately and notify the doctor, because that is an emergency, okay? Now let's move on to the next assessment.
So now I'm going to do the head circumference, which is a measurement of the baby's head, all right? So I always make sure I have gloves on. I perform hand hygiene and put gloves on, because sometimes it takes a while before the baby has had the bath, so the baby has all sorts of body fluids on them, okay? So I'm gonna make sure I have gloves. All right, so here we have our infant, okay? We can zoom in on this, all right? All right, so when we measure the infant's head, we wanna make sure that we kinda keep the hat still on to help the baby keep its body temperature, okay? So we're gonna measure it above the eyebrow, okay? And you always measure this in centimeters, okay? Maybe this one's gonna be easier. Yeah. Okay, make sure you always keep support on the baby's head, okay? So it's always important to do it at the most prominent part of the baby's head, which is the largest part, which is around here, okay? Make sure you grab the back of that, okay? I'm gonna lift up the head a little bit here. It's a little harder, okay? So, it's a prominent part of the baby's head. You're gonna bring it all around and make sure it's above the eyebrows when you do this, okay? So the baby's head's measuring about 36 centimeters, which is normal, okay? Because the findings are within normal limits, would be between 33 and 35.5 centimeters. Okay, so this is normal, which is above the eyebrows. So you're also gonna, while I'm here, I'm gonna remove the baby's hat and check the baby's interior fontanelle, which is a diamond shape, flat, like concave flat surface at the top of the baby's head. And this normally ossifies between 12 to 18 months of age. If you follow the suture line, you will make your way down to the posterior fontanelle. So this is a triangular, small triangular shape, and this ossifies normally by the end of the second month. Okay, so the first thing too, you want to observe the head for any laceration or abnormalities, which is important to notify your physician and the head nurse. Okay, so you want to make sure there's not any abnormalities. You might even find that the baby has a bit of molding going on, cone head, they call it. And this is normal because it helps the baby as passageway throughout the birth canal. Okay, it molds the baby's head to have a better passage. Okay, so we want to check the baby's head, check any abnormalities. Once you're done this, please put back the baby's hat on. This helps the baby keep warm. Okay. So the next thing we're going to move on to is the eyes. Okay, so we're going to check to see if there's any abnormality. You want to check the symmetry of the eyes, okay? Is the outer corner of the eyes lined up to the ears, okay? You want to check that. Is the sclera of the eye, the white part of the eye, is it yellow? Is it white? Make sure you check these. We want to make sure that the infant isn't experiencing any jaundice. You also want to check for strabismus and nystagmus. Okay, so strabismus is when the eyes are not looking at the same direction, while nystagmus is when the eyes are shaking or moving uncontrollably. So these you can check with a pen light, okay, with the little pen light that you have. You want to make sure that the infant, you do not force the eyelids open, okay? You can dim the lights to get a better sight of the eyes, which will allow the infant to open their eyes on their own, okay? So you can take the light and make observation of this. So once we did our documentation, we did our assessment on the eyes, we're gonna move to the nose. So this is when we wanna check the patency of the nose, okay? Babies are nose breathers. You're gonna check the patency of each nair by occluding them, okay? Occluding the nair. Also, you might find little pustule or what pustules on the nose or around the face. This is called milia. This is common. That's okay. It's going to go away on its own. And this is of keratin buildup in the skin. So sometimes you'll find these things. A nurse will give it to you. They're always packaged. This is make sure that it's clean at all times. So this is to be able to aspirate any mucus found in any of the baby's nose or mouth. So the first thing you're going to want to do is take the syringe bulb and press down for suction. You always want to do the mouth before the nose to avoid aspiration, okay? You're going to go into the mouth, suction, okay? Release. Then you're going to the nose, suction, release. Same thing in the opposite nostril, okay? So we found any abnormalities of the nose, anything like that. So we're going to move to the ears, okay? So sometimes you're going to want to check to see if the baby has 2 ears. Sometimes you might have a genetic mutation where the baby only has 1 ear, which is important to examine the ears. You might find a skin tag or pits of the ears, okay? Again, that's another thing that you might want to note down, okay? There could be any hearing abnormalities or just deformation of the ears, okay? And you're also gonna make sure that the ears line up at the outer corner of the eyes as well. So once we did the ears, we're gonna move to the mouth, okay? So always perform hand hygiene, have clean gloves on, and you're gonna want to palpate the inside of the palate with your index finger, okay? Gentle palpation, and this is to identify any cleft palate. Cleft palate can be very dangerous or more of an anomaly for inborns because it can affect their feeding, and can cause aspiration. And you also want to check for tongue ties or any absent pearls, which is like white pustules that are often found in the inside of the mouth or near the gums. And that is because of keratin buildup, kind of like the milia, sort of. All right, so we're gonna make it down to the neck. So this is when we're gonna observe the neck lag, okay? So this is a procedure, a really quick procedure done. So you're gonna expose the baby still has his clothes on, so you're gonna gently hold the baby's arms and you're gonna gently lift the infant, okay? And this is when you're gonna see if the neck is lagging or if the head is lagging, okay? You wanna make sure the baby is able to hold their position of their neck. Of course, they're newborns. They're not going to do this very quickly, but it can take a few seconds. Give it time, okay? Lagging of the neck is not good and needs to be documented immediately, all right? All right, so we're also going to check the clavicle of the infant, which is important because there could be a trauma done to the clavicle during childbirth. We want to check if there's any fractures, any broken clavicle, anything like that, all right? The next thing we're gonna do is the chest circumference, which is when we measure the infant's chest, okay? This should be no less than 1 to 2 centimeters difference with the head circumference. So the normal range of chest circumference should be between 30 to 33 centimeters, okay? So I'm gonna show you how to measure the circumference of the chest, all right? So this is also something that you would do at the last, okay? When the baby's being weighed and the baby's exposed, okay? The chest is exposed. Would be a good time to do it, okay? Also measured in centimeters. So I'm going to expose the infant's chest, okay? And you're gonna measure it at the nipple line, okay? Gently lift the baby, bring the measurement tape over, okay, and joined. So I got a measurement of approximately 34 centimeters, which is normal, which is 1 to 2 centimeters less than the head circumference, okay? Always make sure you move any loose objects out of the baby's bassinet for safety measures. All right, so we did the head circumference. We marked it in my dart charting. So this is another thing we're going to do, which is called the grip reflex, excuse me. Right, so this is a normal response that an infant will have if you put your index finger inside their palm. They will wrap their hands around your index finger. Okay, this is a very good sign. Okay. Once that is done, all right, this shouldn't disturb the baby too much. All right, so I think that's the end of our assessment.
So we are going to do the abdominal assessment. So for abdominal assessment, we are going to inspect the abdomen. So we're going to inspect if it's round or symmetrical. Also, we are going to inspect if the skin of the outer skin of the umbilical cord is clean and also dry. And then we are going also to palpate the abdomen. So while palpating the abdomen, we are going to assess the liver, and also the liver edges should not be close to the baby's ribs. And then also we are going to assess for any masses. While doing the abdominal assessment, we are also going to do the umbilical cord assessment. So the umbilical cord assessment has 3 vessels, so it's 2 arteries and 1 vein. So we should also make sure that the umbilical cord is clean. So if you see a soiled umbilical cord, we are going to have a cotton tip swab and then a warm water, and then we're going to start at the base of the cord and then going upward or outward. Also, we are going to assess the area of the umbilical cord. Is it redness? Is there any redness? Is there any swelling, foul smelling? Also, we are going to check if there's any bleeding on it. Usually it indicates that the umbilical cord stump has loosened, so we need to make sure for the closure, like double check for it. Also, the umbilical cord stump, usually it should be kept dry, and it usually falls off 8 to 10 days. So after the umbilical cord, we are going to assess the female genitalia. So you're going to assess one, we're going to assess if the baby has pads. We have an extra pad in here in case the baby had stool, have any void on it, we can change the pad. So we are going to assess the reproductive system, but it doesn't have one, so I'm just going to assume that there's one. So for female genitalia, the labia should be formed. Also the labia majora is covering the labia minora. Also we have what we call pseudo menstruation. What it means is that it is a discharge cause it is a discharge, and it is caused by the hormonal withdrawal of the mother during birth. So we need to take note of that if the female is if the baby is a female. Also for male, we are going to assess the tip of the meatus. So meatus, that is where the urine or sperm exits. So we are assessing that because some cases the baby they're inside of the tip of the penis, they are located at the lower shaft of the penis, which what we call hypospadias. So we should also take note for that. Also we should take note that we're going to assess the testis if it's descended to the scrotum. So how to do that? We're going to palpate the scrotum, and then we should feel like a marble inside of the, because the scrotum is a sac, so it should feel like marbles on it. That's what the testis is. Also we're going to assess hydrocele. So hydrocele, it is an excessive fluid amount which causes the scrotum to swell, so we're going to assess for that. Also we're going to assess rugae on the scrotum. Rugae, like a little lines or little wrinkles on the scrotum, that's what we call it. And then we're going to assess the anus. The anus should be open. So after the genitalia, we're going to do the GI function. So for GI function, we have what we call meconium. It is the first stool of the baby, and it is past 8 to 24 hours. So if the family is having discharge, we should take note that the baby passed the meconium, so that we will make sure that the GI tract of the baby is patent. Also, if the baby have breastfeed, if it's a breastfeed infant, it is a bright yellow color, and they should pass it 3 to 6 stools a day. Also, if it's a bottle fed infant, it is 1 to 4 days, and it usually decreases to 1 to 2 days, so it varies from yellow to brown. And also if the baby is taking oral iron supplements, the stools will be dark. Also if you see a green watery stool, it is what we call the diarrhea, so we have to notify the healthcare provider about it. Also for the void, if the baby it occurs, like for the void, it occurs during the delivery room, or sometimes may not on several hours, so we need to make sure that the baby voids for the first 24 hours, because if not, we should notify the healthcare provider. And also if the baby voids, we need to make sure that he or she has 6 wet diapers in 1 day. So after the genitalia, we are going to assess the legs and hips. So for legs, we are going to assess, is the other leg shorter than the other one, like stuff like that. Also we are going to assess the hips. So we have what we call a hip dysplasia. It is we also take note of that, because we don't want any misalignment on the hips. And also the physician will have to do the Barlow sign and the Otto-Lange sign, so the physician will do that for us. Also, we're going to assess the feet and toes. So for feet and toes, we're going to assess if there are any crease on the sole of the feet. Also, we are going to count the toes, so it should be 5 on each. So he has 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. So that's perfect. That's what we want. Because some cases babies have extra fingers or toes, so we need to make sure of that also. So while I'm assessing the feet and toes, I'm going to do the reflexes. So we have a Babinski reflex, that's what they call. We are going to stroke our finger on the sole of the baby, and the toes should flare out. We don't want this to see on adults. We have one also, the plantar reflex. So I'm just going to put my thumb, my finger at the toes, and the baby, like the toe should curl on the hand. So that's what we call the plantar. We also have one, the Moro reflex, or what they call the starter reflex. So it should have like a loud noises or unexpected movements. So the baby will raise their hand up, like palms up, and then it will go back to the body after that. So that's what we call the Moro reflex. Also, we are going to assess the weight. So for the weight, we have to undress the baby. So I think this is hard to undress. So I'm just going to assume that the baby is undressed. So I'm going to undress the baby. So example, I address the baby. So before doing the weight, I'm just going to do the spinal assessment. So you can put the baby like this, like at the side. And also we are going to assess the spine. So the spine should be curved. It should be straight. There's no curves on it, because like scoliosis, there's also what we call spina bifida. It is spina bifida and spina bifida occulta. So spina bifida occulta, that's where the gaps between your small bones and your spine. Also, we have to make sure that there's no hair tufts, no openings, or any sacral dimple on the sacral area or the coccyx area too. So after the spinal assessment, that's when we do our weights. So for weights, we are going to undress the baby. And then we are going to undress the baby, and we're going to put in the weighing scale here. So we need to make sure that we're going to lift the baby, like their head, like that. So I'm just going to say that the baby is undressed. So we're going to put it here, and the weight should be in kilograms for that one. And then while also doing the weight, we are also going to do the length. So I'm just going to mark it here at the top of the head, and also at the bottom of the feet, like in here. So after that, I'm going to get the baby in here, get it back here. I'm going to dress the baby. So after dressing the baby, I will get my length. So for the length of the baby, it's usually 45 to 56 centimeters, or 19 to 21.5 inches. Also for the weight of the baby, it should be 6 to 9 pounds. So for the weight of the baby, 5 to 10% most of the time, they lose weight by the age of 3 to 4 days old, because they pass stool and also has limited fluid intake. So after that, I'm going to address the baby, and then I'm going to swaddle the baby and return it to her mom. So what I've said in the video before, for the hip assessment, we're going to do two tests, or the Orlani and the Barlow. So we're going to do hand hygiene, also wear gloves. So we're going to do first the Barlow sign. So for Barlow sign, so this is the thigh of the baby. We are just going to put the thigh toward the midline, or like adduct, and then we're going to put a gentle pressure on it, and that's where you will feel a dislocation. Also, we have what we call Orlani sign. So Orlani sign, we are just going to abduct the thigh of the baby, and you will hear a clunk, and we don't want to hear that. So that's how you do the two tests for hip assessment. Make sure you support the head of the baby too. So after this, we're going to get her here. I'm gonna put this at the side also, like that. And after that, we are also going to ask the mother, what does she want? Or does she need anything else before I leave? Also, I can give her some water, and also like I'm going to make sure that the serials are up, brakes are on, call bell in reach.
and then I'm going to take a look at the last look for the mother and the baby, and then I'm going to document what I find on the assessment.